Everyone. Thank you for joining us today for the 2022 AADOCR and Friends of NIDCR Advocacy Day. My name is Christopher Fox, and I am the CEO of AADOCR. While we are disappointed that yet again we cannot be together in person this year, we're very grateful for this video conference technology and our IT team that have allowed us to host this annual event that connects our members with members of Congress and other influential policymakers on Capitol Hill. So today you're going to learn about the dental, oral, and craniofacial research that is supported by the NIH and NIDCR and the importance of that research for the oral health of our country, as well as hearing from CDC and initiatives in the oral health division of CDC. So you'll hear from two of the top leaders in the country when it comes to researching oral, dental, and craniofacial health and the implementation of federal programs to prevent and control oral diseases and conditions. You'll also receive an in-depth training on how to advocate for federally funded research and oral healthcare programs so that you are well prepared for your meetings with members of Congress and their staff tomorrow. By being here today and tomorrow, you have the opportunity to make an important impact on the amount of funding the NIH, the NIDCR, the CDC, and other agencies involved in biomedical research received from the federal government. It's almost exactly 2 years since the COVID-19 pandemic arrived in the US and changed our lives. It also changed the way we as a country think about biomedical research. There may be greater appreciation today than ever before for the work you and other medical researchers and scientists do every day to identify gaps in our understanding of diseases and to transform breakthroughs in biomedicine into tangible solutions for our patients. So over the next 3 hours, we'll teach you everything you need to know about the federal appropriations process, the legislative vehicles for enhancing our national investment in science and research, and much more. But ultimately, your power and success tomorrow resides in your ability to tell your own story to policymakers about what you do and why that work is important to the health of our country. Let's carry the banner for NIDCR, NIH, the CDC, ARPA-H, and other agencies and make the case to policymakers that federal funding for medical research must be a top priority. Thank you again for joining us today and taking the time out of your busy schedules to advocate for dental, oral, and craniofacial research. I'm now going to turn over the program to AADOCR's Director of Government Affairs, Yehuda Sugarman, and he will introduce Dr. Rina D'Souza, the Director of the NIDCR. Yehuda?
Thanks. Thanks, Chris. And I apologize to everyone. I came down with something a couple days ago. So of course my voice is a little bit shot. So I appreciate you bearing with me today. I am Yehuda Sugarman, the Director of Government Affairs for AADOCR. I really appreciate all of you joining us today. So Dr. Rina D'Souza really needs no introduction with this audience. She's been an incredible friend of our organization and as you all know, is the current director of the NIDCR. In case any of you, though, are not familiar with her impressive background and her accomplishments, I will provide some highlights for all of you. Dr. D'Souza received her bachelor's degree in dental surgery from the University of Bombay in India, after which she completed her general practice residency. She earned her DDS, PhD, and master's degree in pathology and biomedical sciences from the University of Texas's Health Science Center in Houston. Dr. D'Souza has been involved with the NIH in various capacities throughout her career. She is a former NIH grantee, having served as a principal investigator on multiple NIH grants since 1987. She has published over 140 peer-reviewed journal papers and book chapters. Her research has focused on developmental biology and genetics, including tooth and craniofacial development, matrix biology, biomaterials, tissue engineering and stem cells, and regenerative dental medicine. She also served on several advisory committees to the NIH over the years, including directly advising former NIH director, Dr. Francis Collins. Before Dr. D'Souza took over as director of the NIDCR, She was the Assistant Vice President for Academic Affairs and Education for Health Sciences at the University of Utah. There, she also served as a professor of dentistry, the Olin Marty Jensen Chair of the School of Dentistry, and professor of neurobiology, anatomy, pathology, and surgery in the School of Medicine and the Department of Biomedical Engineering. In 2012, she was selected to be the inaugural dean of the University of Utah's School of Dentistry. Of course, we know Dr. D'Souza best for her leadership of our own organization. She was the president of IADR and AADR before we added the oral and craniofacial to our name from 2018 to 2019. Clearly, that position was the right move because the very next year, in 2020, she was appointed by President Biden to serve as the next director of the NIDCR. As director, she oversees NIDCR's annual budget of more than $475 million and the approximately 770 grants, 6,500 researchers, and 200 organizations that are funded by the Institute. I'm pleased to welcome Dr. Nih D'Souza.
Thank you so much. It's an absolute thrill, to be here. I just want to make sure I can get here it is. Can you all see that?
We can just go ahead and start the presentation.
Okay.
Perfect.
Great.
Yes, we can.
Thank you. Thank you, Yehuda. I know that AADOCR is very fortunate to have you on board, and thank you for your efforts in organizing this important day, which for me in my extramural life was really one of the highlights of my year, coming up here and being able to talk to staffers and invite them back to visit labs in Texas and in Utah. So I really have hands-on experience about the benefits of such advocacy for an agency that cannot advocate for itself. So what I want to do, and I'm also, by the way, very thrilled to have Casey Hannon on board as a fellow federal colleague. We work closely with CDC, and we hope to expand that relationship over the next few years. And to all colleagues on the panel, I want to start off by saying that NIH now is in a transition phase, having benefited greatly from the legacy of a very creative, a brilliant leader, Francis Collins, who took the Institute into new directions in many, many ways. And so I was fortunate to have him as a boss and to be sworn in by him in October of 2020. But very unprecedented for us in the field is to have a DDS PhD, one of our own clinician scientists, Dr. Larry Tabak, now at the helm of NIH in a very, keeping the institution very, very stable. And for all of you, this is really once in a lifetime occurrence. So we're very, very proud of Dr. Tabak's leadership role in this transition. For those of you that didn't attend council, you wouldn't know, but I'm thrilled to introduce Dr. Jennifer Webster Syriac, who's on this panel today, who joined our institute a few months ago, comes in with a wealth of experience as a clinician, as an educator, a researcher, and a mentor. And Jennifer's will do a lot for us across NIH, and her own interests will focus attention on health disparities research, pain and neurosciences, helping create the infrastructure for clinical and translational research, and building collaborations across NIH. So welcome, Jennifer, again. We also have the privilege of having Dr. Renee Joskow on board now as my senior advisor. Renee brings a wealth of experience from federal agencies and will be really our spokesperson, our ambassador for the report, Oral Health in America, Advances and Challenges. So what I want to do today is to just give you a quick landscape view of where we are in this pandemic recovery period. I'm going to be bold in saying that. Talk a little bit about NIH and NIDCR and how its mission is shaped by unprecedented opportunities in science and tech that science and technology offer us today that we didn't have even 5 years ago. To talk about the budget and how we are allocated, our key milestone achievements for 21, and how we intend to move science along such that we really do make oral health available to all. So just as a reminder, we were created in 1948 as a public health institution, really, to research dental caries and periodontal disease. These diseases were actually very dominant in society in 1948, causing President Harry Truman concern about the status of our young men who were being recruited to war. And we've kept over these 74 years, so we'll be celebrating our Diamond Jubilee next year. We have kept true to this mission to actually advance knowledge and transfer discovery into health so that what we know becomes part of what we do. So we divided, as you know, the extramural program funds research in a very wide area of disciplines. We cover disease areas, we cover the spectrum from early prevention to management and recurrence. We look at cross-cutting approaches, and we focus on disciplines that are both classic and still very evolving, as well as those that are emergent, such as behavioral and social sciences, implementation sciences, and the data sciences. These are very important today for us to actually be in touch with our community and to identify disparities that both individuals, families, and communities experience. We're very, very privileged to actually have an intramural program on campus run with 27 principal investigators. Matt Hoffman ably directs this program, and it's in 5 different areas. Very much in a translational mode. So we have basic scientists that are doing cutting edge, mechanistic, hypothesis-driven research, and we have clinical investigators who are actually testing new drugs and new products in Billington's clinic. The reason I bring this up is to say that the intramural program offers opportunities for small, short-term training for dental students over the summer, for Harvard Hugh trainees. There's a lot of opportunity available. I urge you all to actually research our website. Our current budget is at 483 million odd, and we're waiting now for the continuing resolution to pass as an omnibus bill this week, and hope then that we have the support we need to move on various fronts. This is how we divide our budget, the majority of which goes to the extramural sector. We have about 10% devoted to research, training, and development. The goal is to increase our resources in this area so that we can actually train a broader array of researchers, especially those that have clinical expertise, but have an interest in scholarship and knowledge creation. So this is the way we divide it up. We remain amongst institutes very favorable in terms of the pay line. So we're funding almost 25% of R01s right now. And that is really hopeful for the future. We will hopefully keep that percentage of support up. Now here, this is not as nice sounding as it should be. Most of our money does go outside dental schools because NIH is guided by the mission to fund the best science. I think over the years, and you will see at the end of this PowerPoint, that the effort is being made to engage and to invite dental schools into our family, into our community, such that we increase funding levels to dental schools. And the reason I am personally committed to that mission is that the knowledge that is generated chairside by students, by you, and faculty mentors is invaluable in terms of how we identify issues and learn to solve them through science and discovery. Now, a quick run through where we are with COVID findings. As you know, we're entering a period cautious, waiting for hopefully being able to handle any new variants that come along through template technology, such that we can rapidly assess the pathogenicity of a new variant and be able to come up with the right mode. I've just learned that this week sometime Congress will be releasing a 5-pillar plan to address COVID from now on. And it's important because part of that plan is to include a global outreach program that makes sure that other countries have the resources that we've had, and also to make sure that we're well prepared for the next pandemic. And you can see here, we've got new findings on pregnancy and antibody. So in addition to the testing kits that you've seen now in the market and mailed to you, actually, there is another arm that NIH developed with a lot of promise for the future, which is looking at therapeutics, looking at drugs that were kind of shelved away, looking at them singly and in combination as potential candidates to mitigate viral proliferation within the body. and to prevent its spread, obviously. So, and you can see that that is well developed now and positions us strongly for the future. We realized through COVID that there was, and I'm sure each one of you have in your own constituents, that there were lots of lessons to be learned. And one of the lessons that NIH had to take very seriously was the fact that science and technology and its understanding has to be much more available to the public. And for that, in order for that to happen, it's important for us to have built, have pre-existing relationships that have been tested and tried, built on trust, really, trust and respect with community organizations, faith-based organizations, pharmacies, state and local government agencies. And this a program called SEAL, initiated by Eliseo Perestable and Gary Gibbons from the National Institutes of Minority Health and Health Disparities and Heart and Lung, is now in place. So this infrastructure is being built across the country and will continue to grow as time progresses. And that gives us at NIDCR the opportunity to leverage from the infrastructure and the relationship building that has occurred so far. We also have right now an investment in understanding long-term effects of COVID, the long haulers, and this program is called Recover. It's based at NYU as a hub and spoke model with several spokes around the country, really carefully assessing the systemic consequences of SARS-CoV-2 infection. Now, what have we done at NIDCR? We had to be nimble and quick, and funded several studies that range from very clinical to very basic science. Many of these projects will be described at the meeting, at AADOCR's meeting coming up in Atlanta. And we've come up with some interesting technologies that I believe will be very useful for oral health in general. You know, the fact that patients now control or responsible in a way for their own health monitoring is a huge step in the right direction. And so with all these technologies that have come forth from the pandemic, the hope is that we can translate that to oral health progress. Now, if you looked at what we possess, in addition to the smiles that distinguish us as unique beings with a sense of well-being, of self-worth, we own these very important biological systems that really are not present elsewhere in the body. We know that the oral cavity serves as a portal for nutrition, for diet, for e-cigarettes, tobacco, alcohol. All of these actually serve as risk factors for the more systemic diseases involving cardiovascular disease and diabetes and metabolic syndrome. So we own these areas. But we also have with us these disappointing statistics. And you can see that here, that oral diseases, as declared by the World Health Organization, is really a very common, most commonly affecting the world with a $500 billion burden. We rank the highest in terms of cleft lip and palate and craniofacial defects. Untreated caries becomes the most common disease of childhood. Periodontal disease is bound to affect a large segment of our population. And sadly enough, HPV positive oropharyngeal cancers are rising to actually supersede cervical cancers of HPV origin. And needless to say, as we look at NOMA, an infectious disease, very prevalent in Africa, in poor populations there, is devastating in children. And we yet do not know its etiology and its pathogenesis well. So we have this in the spectrum of opportunity that we hope will prevent complete tooth loss that affects quite a few people in our country and is linked now to cognitive decline. So we were guided by this, and the report that was commissioned originally by Surgeon General Jerome Adams was transferred in responsibility to NIDCR in the transition to a new administration. And NIDCR took it on with that commitment that we are a public health service organization. This report that was generated by in-depth, data-driven, 400 plus contributors, is a living document that we hope will guide you as the community and NIDCR into the future. Now, if you looked at what has happened in the last 20 years since the first Surgeon General report was released, well, the only Surgeon General report released in 2000, we've had a huge shift in the demographics of this nation. I visited 2 dental schools the last 2 weeks, and I'm so impressed with the progress towards digitization and the technologies there that are being used for patient care and also for communication with communities. The delivery of our services, our deliverables, our disease trends, HPV, one example, changing over these times. We've come up with fantastic discoveries, but yet we are plagued by divides and barriers and schisms in thinking about oral health as being not just a privilege, but a right for all, and that the determinants of health should be taken into consideration as we treat each patient and put them in the context of their family and community settings. And of course, the pandemic itself. So from the report, NIDCR is commissioned, almost charged, to come up with a research enterprise that will help bridge these gaps, that we provide the evidence that can guide the reforms of policy changes, that we reduce the negative impact of upstream determinants. We look at how we can reconfigure the oral health workforce. Reimagining dental education as being much more integrated and affordable is a no-brainer. We just have to do that. And each of you as students should play a role in giving back feedback to your administrators and leaders. And all of this together to eliminate the disparities and inequities that exist. Just to let you know, 2 important kind of bookend public perspective pieces in Lancet and the New England Journal of Medicine highlight the importance, especially of the intersection areas that the report brings to light. Oral health intersects with mental health and substance use disorder. And that was the theme of the New England paper, signifying actually the support of HHS and NIH in this quest. We also have 4 other papers that are coming out, very targeted to specific constituents that will address intertwining themes in clinical practice, education, public health, and research that come through from the report. So whilst we were doing that, NIDCR kept steadfast. We didn't know what was in the report actually until the very end when we did the final editing. But we thought of ourselves and thinking of the 75 years and the 25 years that we have to end the century, that we would be guided by core values of keeping our science excellent, to making sure that we train a workforce that is matching the demographics of this nation, that we are responsible stewards of the pipeline for the future and our resources, and learning to be nimble and embracing and managing change. So the 3 principles I want you to remember and take with you is the focus on translation, so that we take what we know to translate to what we do. And we do that with a diverse workforce and measuring all the way through our outcomes. So we go from strategic priority 1 to 5, well delineated in our plan, and you'll see that it's accessible on our website, that we would go from understanding the molecular determinants that say oral health is connected to general health. So far, we have associations, and they're strong, but we don't have the cellular molecular underpinnings to support these hypotheses. We want to translate that knowledge to individualized, personalized approaches for the right person, the right time, and then go on to translating through implementation sciences, pipeline development, and partnerships with our stakeholders. And Aadocr is one of our key stakeholders. It's important for us to continue to measure outcomes, and we're going to do that. Now, I want to sketch briefly that NIDCR doesn't stay in its own ecosystem, that we are very connected to other agencies and other NIH institutes and centers through these mechanisms. And it's not, our budget is sizable, but it's not, there's certainly other institutes that have far more resources, and it's important for us to be partnering with them in areas of mutual interest, actually. And I want to highlight here the Cancer Moonshot that President Biden is very committed to seeing through, and the next one, HEAL, which is devoted to pain management and opioid use and substance use disorder. Now, we are hoping that through the budgeting process that the promise to increase the money for pain research comes through. NIDCR is slated for an $18 million increase. We're waiting for that approval to come through. Now, what are we going to do with that extra bit of resources? Very, very important for us to focus on joints is one. We're doing that in a three-part collaboration with the Arthritis and Musculoskeletal Institute and the Complementary and Integrative Health Center, and to look at how neural pathways play a role in the pathogenesis of joint disease. We're also actually going to initiate a consortium on the national level that for the first time uses a systems approach to look at temporomandibular joint. We will be interested in natural histories, patient registries, creating a universal thesaurus so that clinicians can be harmonized in their evaluation of patients, looking at early biomarkers and treatment of the disease, preferably prevention more than treatment at the far end, which is normally surgery that doesn't seem to work well. So this is going to be a very important national effort. We also are addressing oral cancers very, very much right up front, hoping now to gather a group of thought leaders, we just did that, who will engage in a collaborative effort, again, a systems approach to look at how best we can prevent the spread of this disease, even though the vaccines are working well. Even though they're working well, males now are affected 5.3 times more than females with HPV positive lesions. Very important to note that data science is moving us forward into the future in many, many different ways. So NIH is developing its own Office of Data Sciences and following the leads at NIH and other institutions actually in the country who are further ahead with this development. Many institutions actually training masters, MSs in data science principles. We're going to be looking at all of this to look at what role we can play. Now, ARPA-H, as I mentioned in council, and we heard from Tara Schwetz, grew from an initiative that was highly successful, the one that the Defense Department used to develop the internet, GPS, mRNA vaccines. It was done with a different mindset of not being curiosity-driven, but more use-driven, which is what are we doing that is of use to our patients? Brings the patient right into the center of all of NIH's work. And it's now going to be part of the Cures 2.0 Act. We're waiting for approval and for assignments, but I can guarantee you this is going to push our research. It doesn't take away from the basic foundational sciences, but gives us this motivation to be a little bit high risk taking, high reward. We did that with the mRNA vaccines and it worked, and to apply it to these other diseases that affect us in oral health. So I want to say that our major initiatives that are the PBRN, engaging our private sector, the Regenerative Forum, and Face-Based continue on with great progress. How they connect with what ARPA-H and HEAL and all these other initiatives that are cross-cutting and integrative will be very important in the future. And we are working with the leaders who are very dedicated in these programs, along with the Temporomandibular Joint Consortium, to move forward in this area. I want to announce that Lynn King now, who most of you have known and interacted with, is in a higher position in charge of extramural activities, council and BSc reviews, and oversees the career and training development branch that Leslie Frieden is now acting chief of. I want to introduce Belinda Hauser, a very lovely special person who's an intramural employee who coordinates our student rotations and internships. Now, for those of you that are in dental school, or those of you engaged in residency programs, you know that there are paths that await you. And these, when you reach the crossroads, you have to kind of go back to where you think you'd be the happiest, what you were created to be. I think that's an important discovery. But in order to get there, it's important to be trained in a mindset that allows you to contribute to our oral health profession. And if you look at what researchers typically do, this is what we do. We test a hypothesis, we come up with feasibility studies, we outline our methods, we perform experiments, and we evaluate them, right? And it isn't such a big gap when you compare that to what you would do chairside. So I am one who believes that the two silos, so to speak, come together such that clinicians and researchers work together because our systems of thinking are really very similar. So here is the sketch of what opportunities we offer at every stage. This is the continuum of career track development. This shouldn't be of surprise to any of you. I'll give you some more details and of course leave my PowerPoint for you to study later. So we have currently, as you can see, special intramural and extramural programs that support a variety of initiatives. I'm very proud of the work that AADOCR has done to guide the success of the Mind the Future program. For those of you that don't know about it, please do research it more. It gives you that opportunity to develop a research on the research track in an academic setting. And so we have Ks and different awards here. And the focus is to get as many diverse interest areas and diverse individuals covering all spectrums of our profession. So currently we support about 18 T32s. We're looking carefully at how we train our DDS PhDs, whether that in fact the dual training is in fact the best way to do it, or is it better to actually be thinking of post-DDS? So these debates are ongoing and we'll be meeting with trainees in Atlanta to discuss this fully, as well as training program directors. So we have, as you can see, training K awards as well. The analysis seems to indicate that those who write F awards, either after their first year under a T32 or independently, actually do have higher rates of success with R01 funding, because writing an F30 gives you that sense of ownership and grantsmanship that you're in charge and will steer your career accordingly. We have a summer dental student award that I hope you will consider to come to NIH. You can see a group here. And you'll be impressed with just the intellectual horsepower, and the environment is just uplifting. You'll be excited to know that we are soon to launch a practice-based research philosophy, or a network within a dental school that provides in an unprecedented way the most diverse group of patients to treat, from very simple to special needs patients and those who are medically compromised. We also have the most diverse group of faculty and students who can learn about clinical research methodology and take this as they graduate. No matter what you choose to do, this remains a valuable experience. So this is a new initiative. We're going to try to make it as successful as possible at first launch, but there are always things you learn as you launch new programs. We have a very firm commitment to advance diversity and inclusion in our grantees, looking at implicit bias in peer review sessions, looking at how NIDCR's own staff are positioned. All of this is going to be delivered in a very concrete manner in a few months. Now, very special on our campus is the Clinical Research Fellowship that is run by Janice Lee's Office of the Clinical Director at NIDCR, where we support the training of DDSs and DDS PhDs who are interested in making a difference to our knowledge frontiers. And you can see the deadline every year is the 15th of September. And so far, it's met its 5-year mark. It's actually in its 6th, 7th year. We've had our trainees placed in very good positions in academic institutions, and some remain at the NIH. So do consider that. Very proud to say that we relaunched the Dental Public Health Residency with a little different twist, having the first year being focused on the CODA-accredited dental public health program, which allows individuals to get certified and receive their license, actually. And then that will be followed by 2 years of an intense experience in an area of need, using the resources of NCI, of HRSA, of CDC, National Institutes of Aging, several of them that have programs that are really crying out for analysis. And we're hoping that our trainees, we only take 2 a year, and we have an excellent class starting this summer, that these individuals become thought leaders for the field, and that this program actually models for other programs in the country. Now, so what do we face? We face these challenges, as I mentioned, they're real. guys. They're real. And they affect you and me and those we love and other communities we serve who don't have access to care and don't probably even understand that having your teeth is more than just a healthy smile, right? There's much more to that. We intend to transform practice and research through these areas, and we want to focus on areas that lend themselves to development, implementation sciences and biomaterials, looking, say, for example, a replacement material for amalgams. That's the need right now. So we have this in mind, along with the dream that Tara Schwetz projected when she talked about RPH2 Council. What if we can develop mRNA vaccines to prevent oral cancers, head and neck and oropharyngeal that are HPV? How about an mRNA vaccine for caries if we look at the downstream product of bacteria? Creating zip codes that target drugs, looking at platform-based interventions, and really coming with important ways to access health disparities. So I dream. I don't think I'd go up to space even if I was offered a free ride, but I do dream of a world where every child can lead a life that is free of stigma and poverty. A world when we can kind of look at a patient as a whole and come up with solutions for disease, looking at that holistic view, looking at a risk factor driven world where environmental factors that affect our health and that are shared with systemic conditions, that we mitigate them to some degree, and that we can actually look at our aging population. We're all going to get there, living with healthy minds, bodies, and uplifted spirits that have a full smile. That to me is something that NIDCR will achieve in the next few years. I want to thank a staff that is highly dedicated and supportive of these ambitious, aspirational goals, some achievable and some will take a few years to get to. But I thank you for your support. I hope you can take messages that you've gleaned from this talk as you go through the day. And I look forward to keeping in touch and giving you an update in Atlanta. Thank you.
Thank you so much, Dr. D'Souza. We really appreciate the time you took out today to deliver that update from the NIDCR. Again, I apologize for my voice. I also want to remind everyone that we are going to be doing a combined Q&A at the end of Casey Hanan's presentation around 10 o'clock or a little bit before that. So if you have any questions, please submit them in the chat box, and Christopher Fox will be moderating that session again after Mr. Hanan's remarks.
Actually, just put them in the Q&A versus the chat box.
Oh, the Q&A section. Thank you. Yes, I see that. Okay. Thanks for the clarification. That should be on the bottom of your screen. So I just want to thank Casey Hanan, the director of the CDC's Division of Oral Health, for joining us today. We are extremely grateful to have him with us for Advocacy Day again this year. As director of the Division of Oral Health, Casey directs programs and develops and implements policies and strategies to achieve the agency's mission, namely to prevent and control oral diseases and conditions by building the knowledge, tools, and networks that promote healthy behaviors and effective public health practices and programs. Excuse me. Casey, who holds an MPH from the School of Public Health at the University of Michigan, previously served as the Associate Director of Policy, Partnerships, and Communications in CDC's Division of Nutrition, Physical Activity, and Obesity. Since joining the CDC in 1996, Casey has received 2 HHS Secretary's Awards for Distinguished Service for developing national health objectives and health communication materials. He's also received 3 Special Act of Service Awards related to his accomplishments in accountability measures, strategic planning, and national leadership conferences. In 2020, Casey was named the 3rd most influential person in dentistry on Incisal Edge's annual ranking. They labeled him the man in the foxhole. Sorry, Casey, I didn't run this intro by you, but I hope that's okay. It's a reference to his 33 years of service in public health, including the 25 years he has served at the CDC. Of his determination and leadership, the publication wrote, "Imagine being the person tasked with writing safety protocols for the entire dental industry. And during the most unsettling and chaotic weeks of the pandemic, Casey rose to the challenge, leading a team of experts to help dentists and their patients get out of lockdown and back into their practices as quickly, safely, and effectively as possible." Casey and his team's research produced infection prevention and control guidance for dental settings during the COVID-19 pandemic, which is an educational video that has been viewed over 3 million times on the CDC's website. I am pleased to welcome Casey Hanan.
Good morning, everyone. Yehuda, thank you for that kind and generous introduction. And thanks to you and Chris Fox for the opportunity to join you today. CDC very much appreciates this opportunity, and it is indeed a pleasure and a privilege to participate in AADOCR's Advocacy Day once again. Let me try to get my slides up here real quick. Assuming you can all see that. Go into slide presentation mode. Okay, assuming all is well,
Perfect,
give me a high
perfect, yes.
sign, Yehuda, if you can. Okay,
Looks good.
Again, we're grateful to be here and to give you a bit of a high-level download related to CDC Division of Oral Health activities and relevant pieces of information that can help you on your Hill visits. And we appreciate very much your carrying water for CDC's Division of Oral Health. Learning objectives today, real briefly, we'll review CDC's role in improving oral health, describe our role in infection prevention and control a little bit beyond the incisal ed piece that Yehuda read from, and then also identify CDC resources to help protect the health of both patients and providers in the context of the COVID-19 pandemic. Start up front with a budget. CDC's oral health program is a program of modest resources, I'm fond of saying. As you can see, our budget in 2021 was $19.5 million. We're grateful for those resources. And because it's a relatively small budget, that it makes it incumbent upon us to choose wisely, to choose investments strategically, and in a way that we leverage CDC resources with other federal and not-for-profit resources throughout the United States. As with NIDCR's budget, most of our money goes out the door in the form of program support in terms of extramural awards. In this case, mostly to state oral health programs and to a smaller extent to national partners. The rest, the operational costs, that's salary, fringes, keeping the lights on, utilities, that sort of thing, is our next biggest cost. Surveillance and research is at 6% now. That's an area we have plans to grow in the future. And then contracts and special programs round out our budget, our appropriations of 19.5. And currently we're at 25 FTE as our ceiling. For those of you who have seen this slide before, this is a high-level, two-dimensional look at CDC, and these are basically functional and operational organizational pieces. The gist of this, what I really hope you take home from this allocation into functional and strategic areas where there's an investment of resources and staff time, is that, as you probably know, CDC is known as the country's health protection agency. So our primary goal is to protect health 24/7. We do that by trying to prevent diseases before they begin, and after they begin, to mitigate risk as they are discovered. So in terms of this slide, up top is where our strategic priorities exist: effective interventions, better care coordination. We see these as the best way to extend the benefits of both effective and cost-effective interventions, especially on dental sealants and water fluoridation. Better care coordination helps us come at medical dental integration strategies as a way to improve access to care and services, especially those on the prevention side. And I'll say more about this in a little bit. Going on down to the right side here, functionally, we are in charge of surveillance, evaluation, and research. We monitor disease burden through surveillance systems and their risk factors. We conduct program evaluation, and we conduct cost effectiveness research. As I've already mentioned, oral health program support is our biggest single expenditure. On the other side, and the other side of this, the part that I just left, those are traditional public health functions. They are not unique to the Division of Oral Health. And in fact, many programs and divisions across the agency focus on those types of functionality. The part that's highlighted in red now are very much unique to our division and focus on the oral public health and the dental side of our content. As mentioned already, we are the federal lead in infection prevention and control in dental settings, trying to ensure that both patient and provider are kept as safe as possible. And like NIDCR, we have a dental public health residency program. It's a longstanding program. It's a 1-year full-time or 2-year part-time program where people are trained through a curriculum to help them address the 10 dental public health competencies. All of this, the gist of why we do this is really found at the bottom of this slide, where we're trying to promote oral health equity for all. And we do that by trying to increase access to both the prevention and the risk mitigation side of the equation, to improve and expand our programs and our partnerships that extend the benefits of those evidence-based interventions and develop the pipeline of evidence-based interventions for the future. So as I mentioned, we invest in school sealants. We ask all of our 20 funded state oral health programs to work on this. This is a required activity. An analysis we conducted in 2016 showed that sealant programs could save the country $300 million by providing sealants to low-income children. Those children are ones at most risk from untreated or early decay. And our analysis shows that programs that deliver sealants to children at high risk save money. Each tooth sealed saves more than $11 in dental treatment costs. Moving on to water fluoridation, providing optimally fluoridated water in US communities will save the country $6.5 billion in dental treatment costs and offers an average return on investments of community water systems serving 1,000 residents or more of about $20 for every $1 spent. Further, at the bottom, communities with water fluoridation, all other things being equal between fluoridated water and unfluoridated water, experience 25 fewer cavities, saving about $32 per person annually by avoiding dental treatment costs and leading to fewer missed days of work and school. On the other side of that strategic priorities was this work we're doing on to develop a national framework for medical dental integration, trying to marry the two professions in a way that cuts across how they're paid for, how their electronic records are stored, how the public sector and the private sector can work together, how health systems, how insurers can do better by making the two disciplines a little bit more accessible. We have the idea of working to formulate a framework that will specify specific actions regardless of what lane you are in. And so in doing this, we have assembled a steering committee. We're conducting an environmental scan of published and gray literature. We've held a series of interviews. This coming May and June, there are planned listening sessions to further inform the national framework. And then when the framework is launched, we're developing a plan for ongoing partner engagement, a la a collective action framework, so that it is jointly owned and the responsibility for the implementation of this plan are shared across all those interested in this area. As I mentioned, we invest a lot. We spend about $1 million of the division's budget a year on surveillance, primarily on the national NHANES system, but there are oral health questions that can be analyzed and published upon both in the behavioral risk factor surveillance youth risk behavior survey from the Pregnancy Risk Assessment Monitoring System, from the National Program of Cancer Registries, and lastly, from the Infant Feeding Practices Study. From those publications, we have created a series of reports and infographics like the ones shown here, where you can see untreated tooth decay declined in young children over the reporting period from 1999 to 2004 through 2014 through 2012 through 2016. And then on the other side, we talk about the work we still need to do with older adults. Some were twice as likely to have untreated tooth decay, and about 1 in 3 adults age 65 and older who happen to be Mexican-American, non-Hispanic Black, or low income, or under a high school education, or current cigarette smokers had 2 to 3 times the untreated decay as the comparison group. So lots of work pointed to that we need still to complete. As you can see, we fund 20 states shown here. I won't go into great detail, but just to say that we had over 40 applications for this funding, and with current resources available, we were able to reach 20 for a core award. 5 additional of those had enhanced awards for medical dental integration. And then we fund 1 territory, Puerto Rico, and we fund tribal organization in Alaska to work on sealants and oral health surveillance. But as you can see, a lot of unmet need. We all know that oral diseases are a burden in every single state, and we would love the opportunity to serve all states in our country. As mentioned, we are the lead federal agency in infection prevention and control, primarily functioning in 2 broad areas: developing guidelines, recommendations, and resources, as well as when there is a breach in infection and prevention and control procedures and there's been a transmission, we investigate those as well. I mentioned that I would share with you key infection prevention and control resources. The last 2 years, we've actually been very productive in this area. The foundations in the lower left, building the safest dental visit. It's a free online training through CDC's Train platform. Continuing education is available for free for those who complete that. We've updated and made available, pardon me, let me go back. We've made available a 10-module slide set series about basic expectations for safe care. And we are constantly updating. One of our most frequently visited web pages is the Q&A, frequently asked questions on infection control questions. And that is a good place to go to begin to identify if your question has been answered before. We are aware that our guidelines need to be updated because the last official update was 2003. This forms the basis from all our IPC recommendations. We are in the planning process for updating this guidance. We'll continue to refer to core practices. We'll identify topics specific to the dental setting for this guidance update. Identify topics where science has changed or new guidance is needed. That will get the priority. And then we'll leverage the additional expertise through the federal advisory committees, such as HICPAC, the Healthcare Infection Control Practices Advisory Committee, to help us get our work done. And guidance updates will be released in a modular fashion after that. We also want to talk about the 2007 guidelines for isolation precautions that CDC and HICPAC are in the process of creating an isolation precautions work group to lead that update. And then infection control and healthcare personnel, we recently updated sections to include the infrastructure and routine practices for occupational infection prevention and control services, and recently updated the epidemiology and control of selected infections transmitted among healthcare personnel and patient. Wanted to share with you some of the research taking place at CDC's National Institute of Occupational Safety and Health. One has to do with assessing interstitial lung disease-related morbidity and mortality among dental personnel that goes from 2020 through 23. Want to summarize the patterns and causes of mortality there, focusing on non-malignant respiratory diseases among dentists who died between 79 and 2018. There'll be a case series examination of pulmonary fibrosis and other interstitial lung diseases among personnel at 6 idiopathic pulmonary fibrosis or IPF treatment centers in the US. We'll also look at lung biopsies through NIOSH's work in this area of personnel who have been diagnosed with IPF. Exposure assessment of dental clinics and laboratories. We're evaluating exposure to a variety of particles such as dust, silica, metals, ultrafine, and volatile organic compounds in dental clinics and in the labs, importantly. And then we're going to be looking at NIOSH, again, effectiveness of source controls for aerosol mitigation during dental procedures. And this is looking at the effectiveness of dental evacuation systems and mitigating aerosols generating procedures such as crown preps or ultrasonic scaling in simulated laboratory settings, and planning to expand that study also into dental clinic settings. Before I get on to the dental public health residency slide, which is my last one, I just wanted to share with you verbally some of the impact of the COVID pandemic had on the guy that Yehuda mentioned as the man in the foxhole. It was a busy couple of years, especially most of 2020, for us to respond to and take care of the needs of dental healthcare personnel and dental settings. So you might know that CDC across the board, many staff were deployed on anywhere from 30 to 90-day stints over at the operations center and the task forces to respond to COVID-19. You might remember in March 17th, almost 2 years ago, that dental facilities were recommended to postpone elective procedures. 20 days after that, CDC released the first interim infection prevention and control guidance for dental settings. And then on September 10th of 2021, there was the archiving of guidance for dental settings in transition to the interim infection prevention and control recommendations for all healthcare personnel during the coronavirus disease pandemic. The impact of the pandemic as seen and felt from CDC's oral health program was there was a big disruption in preventive oral health services. And I think the data from that will be borne out over time in terms of just what health debt happened among people in need of care. And then with regard to our own DOH state-funded programs, the lack of access to schools due to COVID-19 greatly impacted both our school sealant programs and our basic screening survey program activities. And basic screening survey is what states conduct, usually among third grade students, to get an idea and document oral disease burden among that age group. And then water fluoridations, importantly, through our state programs, we understand training of water system operators and lab capacity to conduct water analyses were hindered a great deal and are slowly coming back online. Related to the public health residency program, I mentioned a lot of this already. You can see the program requirements here. There is a field experience and then a certificate of completion, and it allows the resident at that point to sit for the boards to be certified as a diplomate through both a written and then an oral examination process. And I know I've pushed the time a little bit here. I will stop there. Thank you deeply and kindly for the opportunity to be here and your time and attention this morning. And I look forward to trying to answer whatever questions you might have in the time we have remaining.
Thank you, Mr. Hannon, and thank you, Dr. D'Souza, for your earlier presentation. I think we'll take it up to about 10:10 and get to just a few questions that are in the Q&A. And let me go in order. And we first have a question from Dr. Sheila Riggs from the University of Minnesota. And I think this is directed towards Dr. D'Souza. With the emphasis on translational science, what are the 1 to 2 most impactful research findings in the last decade that have been translated into practice in dentistry? So it's a good question in terms of you may get this question from policymakers. So
yeah, thank you, Sheila. From very recent, I would say the COVID, the discovery by our intramural investigators that worked in collaboration with several groups around the country was to show that the virus SARS-CoV-2 had the ability to attach to oral mucosal cells, divide pretty prolifically in salivary glands, resides in the oral epithelium as in the tongue, all of that being correlated with symptoms, symptomatology. And in fact, I think it drove salivary diagnostics development in terms of COVID testing, but it also gave us an insight that in addition to the nasal lung axis, the oral gut axis might actually play a role in the disease manifestation. To me, probably the most striking of translation came from Jane Weintraub's work, pioneering work, when she was part of the diversity center that was based at UCSF. And she was able to convince and take what we have seen as a preventive strategy and make it part of the policy in implementing sealants and preventive care for individuals in California. So that was an important one. There's scores of examples where we've had biomarkers that have turned out to be screening agents for cancers. HIV, clearly integrating HIV with medicinal practices was another example of implementation that affected a large percentage of patients who were HIV positive. That there's a scope for more, absolutely, Sheila. I would say that that's really a direction we need to go in.
Very good. Thank you, Dr. D'Souza. The next, we have two questions actually from Jeremy Oliver, who's a student at University of Maryland, Baltimore, somewhat related. So I'll just combine them into one. And again, it's directed towards Dr. D'Souza, but it's about how to encourage greater involvement from dental schools in applying for NIH funding to support research endeavors. And then the second part of that question would be some trainees, such as oral maxillofacial surgery, may find it difficult to pursue meaningful research concurrently with their training. What strategies does NIDCR have, and as well as funding mechanism tailored towards residencies?
Both of these are very good questions. Thank you, Jeremy. NIDCR, as you know, will continue to cultivate a group of well-informed scholars of dentistry. Now, this goes beyond our traditional basic science discipline. As I've mentioned before, I think public health and clinical research, as in patient-oriented research, those individuals will be drawn into the fold. Now, what are we doing specifically to inform trainees about the importance of advocacy, the importance of being spokespersons for oral health, will really reside in the individual's own initiatives. And the fact that the student research group that we have as a great forum for interaction that AADOCR has grown over the years into a vibrant group should take this on. That would be my suggestion. And NIDCR could be lending support in terms of materials and resources to cultivate that. Now, the question of where is the time in a clinical program to actually do research? Well, if the research is part of what you do as a clinician, you're operating on cancer to remove a portion of the mandible, and you're concerned about the level of pain that the patient endures post-operatively. Terrible. There is nothing that can actually alleviate the pain. That is true. Or half the tongue is resected with the mandible. Get involved with that. Ask the right questions and take your clinical observations into a meaningful study. So that's really what's going to be happening. There'll be opportunities to support that kind of bridge building between clinical experiences, whether in the community or chairside or bedside, into practice.
Great, thank you. Thank you, Dr. D'Souza. We have a few more questions, but I want to make sure we get one for Mr. Hannon. And you focused a lot on fluoridation, rightly so. And I'm just thinking tomorrow when they're in video calls with policymakers, they may get a question about fluoridation. And as recently as last Monday, we had a member of Congress do I think it was called a Mineral Monday, which sort of raised questions. So I'm sure everyone on this call understands and knows the science and the benefit of water fluoridation. But what do you say to policymakers in a sort of an elevator speech response on the safety of water fluoridation?
Great question. Chris, and I think the high level message for most is, especially because the media has picked up on some more of the recent studies that are looking at potential neurotoxic impact of ingesting fluoride as a child or for the mom during pregnancy. We remain deeply concerned about the science behind water fluoridation, and we reach out, we connect with partners. The gist of where we're at right now is we're very concerned. We want to make sure that the science is as strong as it possibly can, and that we take our job seriously of monitoring and are vigilant on the science. And in that capacity, we have started having listening sessions with authors of recent studies, going all the way back to the Canadian and the Mexico cohort studies and those that have come out recently. And so we're monitoring it. We don't believe that the preponderance of the evidence right now, the scientific evidence, is going to result in, currently to be, to change the policy position of CDC at the moment. It still is, from the aggregate of the data, a very safe and effective mechanism. But with time, even if the data turns the cost benefit analysis in a certain direction, we'll reevaluate those decisions with other policy setting agencies such as the EPA and the US Public Health Service, which updated the fluoride recommendations in 2015.
Great. Thank you for that. And I know there's a lot more behind that, and we could have another whole day on this topic, but we probably only have time for one more question. So let me go to Kristen McKinney's question from Seattle Children's Hospital. And I think this is again directed towards Dr. D'Souza, but being in a setting where the costs of research, especially personal time, have been increasing dramatically in a very short time, personnel time, sorry, not personal time. What strategies is NIDCR being considered to address this?
Thank you. In fact, I omitted the slide because time constraints, but our purchasing power is keeping up with inflation. So our budget is really not reflective as to what we actually have to support. So you're absolutely right, Christy. I think that calls for increased funding, but also very deliberate and intentional funding so that we get the maximum return of investment for everything in our portfolio, right? So one way, I want to give you an example. Through the pandemic, we were very careful to support our trainees, especially those with Fs and Ks. The Ks were finding it difficult to transition to an R00. We've offered additional extended funding and additional supplements to clinical trials, individuals who are doing clinical trials, where it was difficult to recruit patients in this time. So we've kept a watch out for pandemic-related consequences, as well as the overall trend that research is getting far more expensive. Dentistry is getting far more expensive. Debts values are rising. Investments in digital technology are going to cost schools at the expense of research. I understand that. And keeping equipment upgraded and modern is another challenge. So we have many that we need to face together as a community. Thank you.
Great. Thank you very much. And with apologies to Drs. Ianadu, Yellick, and Gilliman, we're going to have to cut the conversation off at this moment. But you know where to reach Dr. D'Souza and Mr. Hannon with their emails. We'll share these presentations after also. And they are some excellent questions, and I apologize we won't have a chance to get to them this morning. So I will turn the program back over to Yehuda, and I think we have a 5-minute break before we start again. Is that correct?
Yeah, we'll take about a 3 to 5 minute break, and then we'll go into the training session. Thank you so much, Dr. D'Souza and Director Hanan, for your really helpful comments and remarks. So we will reconvene in about, again, 3 or 4 minutes, and then we will do the training segment of this webinar. So please stay online.
Thank you very much.
Thank you again.
Hi, everyone. For those who are joining us now for this segment of the training webinar, my name is Yehuda Sugarman. I'm the Director of Government Affairs for IADR and AADOCR. I apologize for my voice today. For some reason, assume to have lost it in the last 24 to 48 hours. I have tested negative for COVID 3 times in the last 2 days. So you're all safe being on this webinar. You're not going to catch anything. Anyway, I just want to, in terms of the schedule today, just quickly run through it. We're going to have a quick update from Syriac Katoja, our chair of our Government Affairs Committee, who's going to quickly give you an update from that committee. And we're going to go to Megan Riley, one of our professional consultants and experts on legislative processes and the appropriations process. Then I will run through a quick legislative update on our top advocacy priorities and our official asks for the day. We will then do a combined Q&A at around 11:10, so in about 45 minutes or so. And then we'll go through some kind of tips and tricks and other recommendations for how you can be successful in your meetings with congressional staff tomorrow. And there will be an opportunity for people to also raise any questions they have about their schedule, about their meetings, about any conflicts tomorrow at the end with us. So with that, let me turn it over to Syriac, who will give you an update from our Government Affairs Committee.
Thank you very much, Yehuda. Good morning, everyone. Thank you for being here for the 2022 Advocacy Day. My name is Syriac Katoja, and I'm currently the Associate Dean for Research and Innovation and also Professor of Restorative Sciences at the University of Oklahoma College of Dentistry. I've had the honor of serving as the chair of the AADOCR Government Affairs Committee, or the GAC, since 2018, and I will end my role as chair at the end of this particular event. The Government Affairs Committee advises AADOCR staff and the board of directors on policy decisions for the organization and reviews the potential impact of policy proposals on research, and particularly dental, oral, and craniofacial research. Members of the GAC also serve as advocates to help advance the priorities of our members. We advocate for increased federal funding for dental, oral, and craniofacial health research through our participation in meetings with federal lawmakers, responding to online action alerts, and posting on social media. Over the last year, the GAC has reviewed dozens of coalition letters, some spearheaded by the AADOCR, to ensure that they align with the mission of the organization. The letters are typically addressed to congressional leadership, agency heads, members of the administration, and others to advocate for greater public investments in access to dental care, dental workforce training, pipeline diversity, oral health literacy, disease prevention, and research, among other things. Last year, the GAC selected Dr. Kathleen O'Loughlin as the winner of the AADOCR annual Jack Hein Award. The Jack Hein Award was established 25 years ago to honor an AADOCR member each year who has given exemplary service in the area of public affairs by consistently promoting the interests and activities of oral health research to a wide constituency. Dr. O'Loughlin, as many of you know, was the executive director and chief operating officer of the American Dental Association for 12 years before she retired at the end of 2021. She will be awarded a recognition plaque at the annual meeting in Atlanta in a few weeks. In addition, later on today, the Government Affairs Committee will be voting on the winner of AADOCR's National Student Research Group Student Advocate Award, which recognizes one student each year for outstanding contributions in advocacy for oral health research. And the winner's name will also be announced at the AADOCR annual meeting in a few weeks. With that, I am now going to turn it over to Erin and Megan from CRD Associates, who are our professional lobbying consultants, to give an overview of the federal appropriations process, including how federal agencies like the NIH and NIDCR our allocated funds each year and will train us effectively to deliver our message to Congress tomorrow. Thank you once again for being here.
Thanks, Syriac. It's nice to be with you all this morning, and I'm looking forward to the Advocacy Day tomorrow. Apologies on behalf of my colleague, Erin, and I know many of you have known her over the past few years. She had an emergency come up and is not able to join us, but I think you'll be in good hands with myself and Yehuda. I'm going to go ahead and attempt to share my screen here for my PowerPoint. Can someone confirm if that's visible?
It's visible, but you're not in presentation mode.
Okay, let me just see if I can. Sorry, I'm clicking slideshow, but I think I might be on the wrong.
Yeah, I think slideshow on the top.
Yeah.
From beginning. Yep.
All right. Did that work?
Yeah.
You're in presenter mode. If you go to the top and that display settings drop down, you should be able to swap the two screens and then we'll see the correct one. Perfect.
Okay, thanks. Sorry about that. Always, even 2 years in, we can always have some technical difficulties still. So today we're just going to go through a high-level view of Congress and what happens in the appropriations process. As Yehuda said, he'll give an update on legislation and our advocacy asks for the day tomorrow, and then we'll do tips and tricks on meetings. So that's just the agenda. Starting with the real basics of Congress, and apologies for those of you who are experienced advocates, but I think it's always good to give sort of a high-level overview of Congress and its makeup. So 2 houses in Congress, of course. The upper chamber is the Senate. 100 senators represent the 50 states, and each state has 2. So senators represent the entirety of their state, from the biggest cities to the smaller rural areas, suburbs, etc. Senators come up for election every 6 years on a staggered basis. And that means sometimes, if a senator is not up for election for another 5 years, they might be a little more free with the way they vote. You might see them make some different choices than if they're up for election and they're kind of towing the party line or really going for votes that year. In the House, there are 435 members and 6 non-voting delegates that represent the various territories. Every member of the House represents a geographical district of a state based on population. So House districts might skew in a certain demographic direction, and members may represent certain special interests within the district. Every seat in the House faces election every 2 years. So unless a House member is choosing to step down, they're essentially always running for re-election. In both the House and the Senate, members are divided into committees which have jurisdiction over particular areas of government. I'm sure we're all probably pretty familiar with this cartoon from our childhood, but just a basic overview on how a bill becomes a law. There's a very specific process by which this is supposed to happen, and we'll go over that. In practice, the process can get a little bit messier, and Congress doesn't necessarily always follow its own rules, but they have other ways of advancing legislation. To start, a bill is introduced in Congress. The relevant subcommittees then hold hearings and a markup. A markup is a meeting of the subcommittee in which the members can debate and amend a piece of legislation before passing it up to the full committee. So then the full committee does the same thing, holds a markup, and then reports the bill to their respective chamber, either the House or the Senate. So separately, the House and the Senate would debate, amend, and pass a bill on their floor. And since bills rarely move through the chambers identically, the 2 houses have to meet in what's called a conference committee to resolve the differences after each chamber has passed a bill. Then the final bill, which we would call a conference report if it came from a conference committee, goes back to both chambers for final passage. Instead of a formal conference, one chamber can choose to vote again on the other chamber's version of the legislation. But just what needs to happen is each chamber needs to pass an identical version of the bill before it goes to the president for signature. Rarely does this really happen by all those steps. Sometimes committee work is skipped. Sometimes the House and Senate come to an agreement before passage and they won't need to do a conference committee. Sometimes, they'll change the rules for debate on the floor and there might be limited or no opportunity to amend a bill. But always, the House and Senate must both pass the bill in identical form before it moves on to the president for signature and becomes law. There are two different types of legislation: authorization legislation and appropriations legislation. Authorizing legislation creates, expands, or changes federal policies and programs, or it can alter government functions and responsibilities. Authorizing can also refer to Congress providing the authorization to spend money on a particular program or initiative, but just because Congress authorizes funding does not mean that the spending happens. For that, you need appropriations legislation. So you've heard probably the expression that Congress has the power of the purse. They exercise that through appropriations legislation, which provides budget authority to federal departments and agencies and specifically allocates federal spending. The appropriations process occurs every year with the federal fiscal year beginning on October 1st. Congress often misses its appropriations deadline, and then they have to enact what's called a continuing resolution to keep funding going, to keep the government open until they're able to come to an agreement. So we'll talk a little bit more about that when we look at this timeline. So we want to focus on appropriations because that's what the main number of your asks tomorrow in your meetings will be. So the chart here on the slide is a version of how the appropriations process works. And I say a version because, like the overall legislative process, the appropriations process doesn't always go by the books. And this year we're in quite a pickle with it as well. So we'll talk about that as we move on. But how it is supposed to work, the president releases a budget in February. That's a non-binding proposal mapping out the executive branch's budget preferences. And after receiving that, and the Capitol Hill can sort of use it as a reference point, as a guide. In the spring, the House and Senate would each ideally pass budget resolutions through their budget committees and on the floor. And the budget resolution would establish the overall discretionary spending level for the federal government. And then the work moves on to the House and Senate Appropriations Committees, and they do really the lion's share of the work here. First, they will separate out the budget allocation into 12 different allocations corresponding with the 12 spending bills. Those are known as 302B allocations, and they determine, what amount of money goes to each jurisdiction. So there's the labor, HHS, education, related agencies spending bill, which we will focus on, and that will have its own 302B allocation. In the spring and early summer, typically each of the 12 subcommittees will draft their bills and hold a markup. And then once the subcommittee passes it, the full committee will do the same, and it'll go to consideration on the House or Senate floor. Again, like the typical process, ideally a conference committee would follow, and then the president would sign the bill by the end of the day on September 30th. But in the real world, that's pretty atypical. While the annual appropriations process is one of Congress's highest priorities, perhaps the highest priority, they rarely finalize all 12 spending bills by the end of the fiscal year. And when they aren't able to do so, again, they really have to pass what's called a continuing resolution. And that would typically extend funding for a temporary period of time at the existing funding level. And it gives a bit of a cushion for Congress to keep negotiating and come up with a final bill without shutting the government down. So, and in that case, after we go through a CR or a series of CRs, appropriations bills are often packaged together at the end of a process into an omnibus bill or a couple of different smaller vehicles in order to get them through the floor without using too much time up. So now let's talk a little bit about where we stand today. This year has been even more prolonged than the normal appropriations process. So there's been a pretty big lack of bipartisan agreement over the past few months, which risked federal government shutdown, but we haven't gotten there. We've kept the government operating. So Congress has passed a series of CRs, even though the current fiscal year began on October 1st of last year. We've seen 2 or 3 CRs, and right now, the existing one has the government funded until this Friday. So this is a really big week in terms of what's going to happen with appropriations and where we're going to see the rest of FY22 funding land. Appropriators announced last month that they'd agreed to a framework for constructing a final FY 2022 appropriations bill. So they passed this CR until March 11th to give them the time to write that bill and get it through the process. But as of this morning, we've not seen a bill yet. So there's quite the time crunch here today, because there's a lot of other things going on as well. In terms of supplemental funding requests for Ukraine and supplemental funding requests for COVID, there's a lot that needs to go into this package. And essentially, the House will need to vote on it probably tomorrow or Wednesday, and the Senate would follow after that. So we're sort of on pins and needles waiting to see what comes up. I read the news this morning, and leadership is still saying that they aim to pass the bill this week. So we might have news to share, as you're working through your meetings. But I think the most important thing to keep in mind is that we're still in the midst of this FY 2022 appropriations process. But as we head to the Hill, or the virtual Hill, we are going to be talking about investing in biomedical research and oral health programs for fiscal year 2023. And that is it sort of for the landscape. And I'm happy to turn it over to Yehuda to talk a little more in detail about the asks for tomorrow.
Thank you, Megan. And I appreciate you all bearing with me while I try and go through all of our messaging with about half of my voice left. So thank you. And we will do Q&A after my presentation. So if any questions came up, if you could just hold those. You can also jot them down in the Q&A section on the bottom of your screen. So I'm going to run through a quick legislative update of where we're at, just kind of building on what Megan was talking about, and then go through our specific asks after that. So we can go to the next slide. And okay, so legislative update. So, as Megan was alluding to, we are in an interesting period right now. It's probably one of just a few days in the year. There's a few of these CRs now that pass every year, but where we're kind of in this interim holding period between continuing the existing funding for 2022, but also getting off the ground the 2023 fiscal year appropriations process. So what we've decided to do is to quickly in our messaging mention the need for passing a federal budget for 2022, finalizing that process. But our specific asks in terms of the funding levels are going to be for 2023. So that's an important distinction to make. So again, just as a background, the fiscal year 2022 began on October 1st of last year. And we are currently under this continuing resolution, or CR, which you'll hear a lot about, which runs until March 11th, or this Friday, due to the disagreements between the parties on funding levels. We do understand that appropriators have agreed to a framework, so we're optimistic that there will be a omnibus funding bill. That just refers to a large package, which includes the 12 appropriations bills, along with some other possible mechanisms for funding priorities of legislators. As Megan mentioned, aid to Ukraine is one of them, possible targeted COVID relief, we will see. But we, again, hope that that will go through this week sometime. We have been urging Congress over the last several months to pass a full fiscal year 2022 budget because of the detrimental impact of these CRs on medical research and science. It's important to understand the House and Senate both passed their own versions of the 2022 appropriations bills. That bill, again, as I think Megan mentioned, is called the Labor, Health, and Human Services, Education, and Related Agencies Bill, which for short is LHHS. And so that's the acronym you'll want to remember for tomorrow. And that is the appropriations bill that funds the NIH and all the underlying agencies, including the NIDCR. The House bill authorized $46 billion for the NIH this year, 2022, and $519 million for NIDCR. Our asks, which I'll get to, are based on that House funded level. We're assuming, hoping, advocating for the House passed funding bills. But so you know, the Senate appropriations bills were lower than that. They were $45.5 billion for NIH and $515.7 million for the NIDCR. So again, we're advocating for Congress to pass the House bill, which has those higher authorizations. But the figures itself will be for 2023. So hopefully that's clear. ARPA-H, I think most of you have heard of it by now, and it's been mentioned a couple of times today. It is the Advanced Research Projects Agency for Health. It was an envisioned new agency that President Biden proposed last year in his 2022 budget, which would utilize the DARPA model to accelerate the development of novel treatments, diagnostics, cures, and preventative measures that will improve health. Dr. D'Souza talked about its possibilities for dental and oral health as well. It's seen as a potential incubator for breakthrough medical innovation, and it would support transformative, high-risk, high-reward translational research that would kind of fill that gap between the current medical research enterprise at the federal level, NIH, NIDCR, and the commercial side. It would fill that gap. It would maintain an environment of two-way collaboration between federal research and commercial or private research rather than competition. And this proposal, this ARPA-H idea, has received early support on both sides of the partisan aisle. In those FY22 appropriations bills that I just mentioned, the House designated $3 billion for ARPA-H, while the Senate proposed $2.5 billion, $2.4 billion exactly, for the new agencies, which are both significantly less than President Biden had proposed, which was $6.5 billion. But those are significant investments, and we are not going to get into tomorrow the exact figure that we want to see ARPA-H funded at. We just want it created, authorized, established, and funded at whatever level we can. And then, you know, in forthcoming appropriations bills, we will advocate for the highest possible funding levels. Again, it is extremely unlikely that the 2022 omnibus appropriations bill will include ARPA-H, but there are alternative paths, which I'm going to get into, for establishing this program. Most notably, the Cures 2.0 Act and the ARPA-H Act. Those are two bills that we will give you some messaging on today. We support both of those legislative proposals, but we will be specifically advocating for the latter, the ARPA-H Act, introduced by Representative Eshoo from California. That legislation would authorize a new agency as a standalone entity under HHS, the Department of Health and Human Services, with an initial authorization of $3 billion. I can report that it has received a good amount of support. It has, I want to say, 55 or 60 co-sponsors. The Energy and Commerce Committee held a hearing last month on February 8th to talk about ARPA-H and explore how to advance it. There were some partisan divisions. There was, concerns about bureaucracy, federal bureaucracy, and how it'll be structured. But overall, there was strong bipartisan support for the agency and its mission. So we're sending you into these Capitol Hill meetings, virtual Hill meetings tomorrow, to advocate for something, a new agency that has broad support. And so we think we're setting you up for success. On Cures 2.0, that is a bill that many of you have heard of. It is the follow-up initiative to the 21st Century Cures Act, which passed Congress in 2016. It was introduced by Representatives Diana DeGette and Fred Upton. Representative Upton is a Republican from Michigan, Representative DeGette, a Democrat from Colorado. The bill would streamline and improve medical care, advance biomedical research. It overhauls telehealth provisions, and it would authorize a range of new drug research, among other things. It also importantly includes the full Research Investment to Spark the Economy Act, also known as the RISE Act, which allocates billions of dollars for research, including $25 billion for federal science agencies, $10 billion for the NIH, I think $3 billion for the National Science Foundation. It authorizes ARPA-H with an initial appropriation of $6.5 billion. It's aspirational, it's broad, and it's a really impressive medical research, cures, and preventative health bill. It is really, I think, the gold standard for legislation in the realm that we care about, biomedical research and cures. And it has strong bipartisan support. This bill has close to 90 bipartisan co-sponsors. So we may reference it. You can reference it in your meetings. It may very well come up in your meetings. Staff may mention it to you. So you should be familiar with it. But we're not going to specifically talk about it. Just you need to understand how that intertwines with ARPA-H and NIH funding. You should also know that AADOCR submitted a letter to the sponsors of this legislation in December, thanking them for introducing the legislation and in particular for the inclusion of the RISE Act and the ARPA-H provisions. So we can move to the next slide now on training materials. Everyone in their email, confirmation email, I think it was called Know Before You Go, should have received a link to the briefing materials for today. So if you can pull that up on your screen alongside our presentation, that will be helpful. Specifically the talking points document. You can find it at the link at the bottom of the Zoom webinar. You can also just go to our website and go to the Advocacy Day page. All of the materials for today and for tomorrow on that page, on our Advocacy Day webpage. But that will be helpful to have that talking points document in front of you. And we'll get to the co-sponsors document as well. So on the next slide, about AADOCR. We have this slide because in your meetings tomorrow, in terms of the structure, and Megan will get into that a little bit later in terms of just good tips for how to lay out your meeting. But one of the probably the best way of opening the meeting and introducing yourselves is talking about our organization who you're representing, and our two organizations that are hosting this this Advocacy Day. The American Association for Dental, Oral, and Craniofacial Research is a nonprofit organization with more than 3,000 members in the U.S. Our mission is to advance research and increase knowledge for the improvement of oral health. We support and represent the oral health research community, and we facilitate the communication and application of research findings. You should know that brief paragraph about our organization is also on the bottom of the asks sheet, which is one of the leave behind materials that staff will have access to. So they will have that information as well. Next slide. The Friends of the National Institute of Dental and Craniofacial Research, the NIDCR, is a broad-based coalition of academic and research institutions, professional associations, foundations that champion NIDCR. There are about 50 or 60 organizations that belong to this consortium. The organization or the coalition, I guess, represents the interests of patients, researchers, educators, clinicians, and students, and the value they find in NIDCR and its critical research. And again, there's another paragraph about NIDCR on the asks leave behind sheet that we'll be giving to members of Congress and their staff. So next slide, making the ask. It's very important in these sort of meetings to make a very direct and very specific ask. It's easy to talk about who we are and what and kind of policy issues and the importance of them. But at some point during the meeting, you want to really be very clear about what our ask is. And on the talking points document, you'll see at the top our very specific asks, our primary ask and our background asks, and that is on the asks sheet that we'll be giving to members of Congress as well. You can start with something like, "We're here today to ask your boss to," or "We ask that you support," and to reiterate that point at the end of your meeting as well. Here is on the next slide, our key advocacy day ask. Continue building upon the scientific progress by providing robust federal funding for the entire health research enterprise. We're talking about federal funding for health research, including the NIDCR and the NIH and all the federal health agencies that demonstrate the promise of research, which includes the CDC and other agencies as well. Keep in mind, members of Congress may look to cut or terminate programs that don't have a vocal base of constituents. They generally want to hear directly from the constituents. You are their constituents about the programs that are the most important to you. We champion the work of the NIDCR year round, no question about it. We're in touch with members of Congress and the staff all the time. But you are the people who they really answer to, and they want to hear from the most. So keep in mind that your messages tomorrow should and generally will be well received. When constituents speak up in support of federal agencies and programs that are most important to them, members of Congress and their staff have to think twice about supporting a cut to one of those programs, regardless of what side of the aisle they're on. They need to know that their constituents will hold them accountable, and there may be ramifications to slashing medical research. That said, never say, I will vote for you or against you in these meetings. We cannot say that. We like to focus on the positive and talk about how much we appreciate the support for NIH. Generally, every member of Congress is going to tell you they support it, or the concept of medical research. So we want to be thankful and appreciative for their support. And we've been very fortunate to have such strong bipartisan support for medical research for many years, but we can't take that for granted and can't be complacent given the political environment that we're in and frankly, the fiscal environment we're in either, in which we're operating. So, as I think many of you know, there's not a whole lot of bipartisanship going on. So anything and everything funded by the federal government is at risk. So we need to keep that in mind. Let's go to the next slide. This has a chart of where we've been and where we are in terms of NIH and NIDCR funding. It goes back to 2017. As you see, we've successfully, as a coalition, as a larger medical research advocacy coalition, have been successful in increasing that funding for these federal agencies for many years, from $34 billion just 4 years ago to what we're looking at is somewhere in the mid 40s for NIH billion in 2022. That House level in FY22, is the level that we put in there, the figure that we put in there, because that is the higher figure that was funded rather than Senate, as I mentioned earlier. And that is the figure that we're basing our 2023 ask off of. So kind of assuming that the Congress passes it at the House level, and then our 23 ask is a increased percentage based on that level. That's where we get the 50 billion for NIH and the 558 million for NIDCR. Represents about a 7.5% increase over 2022. Keep in mind There is no 2023 figures anywhere. The committees haven't acted, and the president's budget, which generally is released in February, has been delayed due to the scheduling of everything in 2022 appropriations. But we do expect to see a budget proposal from the president sometime in March, probably in the next couple of weeks, in fact. So this is where we've been, and this is where we're at for 2023. So next slide, our key messages, as I mentioned. NIH, the agency's budget, this is to justify the increases that we're talking about, must keep pace with inflation and the Biomedical Research and Development Price Index. You're going to hear about inflation in your meetings, probably especially from Republican offices, as a way to tamp down support probably for increased federal funding in 2023. But it is necessary for the federal agencies to continue doing what they're doing, and we need that meaningful growth in 2023. Then NIDCR request proportional. That's a key word. Generally, we've seen this, but not always, and we've seen proposals for certain institutes under the NIH to receive a lower percentage increase than the larger agencies. Some receive more, some have received less. So we want to see a proportional increase to NIH's increase in 2023. So if NIH goes up 7%, for example, we want to see NIDCR go up 7%. We don't want it shortchanged. And this figure, you should know and go in with confidence that it has the support of the larger oral health community. The ADA, ADIA, these are organizations that I think you're familiar with. They're requesting the same figure for NIH and NIDCR in 2023. And the figure represents the needs of the dental research community. Also, in terms of medical research, there's a lot of research going back years in terms of American support for investing in biomedical research. A January survey conducted by Research America showed that 8 in 10 Americans say that investing in research is important to economic growth and creating jobs. 8 in 10. Across the political spectrum, Americans agree that it's important for the U.S. to be a global leader in health research. That's 85%. 85% also acknowledge the importance of health research efforts on a global scale. 2/3 of Americans, or 65%, agree that the federal government should be investing in prevention and the cure of diseases wherever they occur. So there's extremely strong bipartisan support for biomedical research. So those are good talking points for you to have in your back pocket. So just going through, kind of staying on this slide, but moving to the talking points document. Look through these bullet points. Our primary ask. We want passage of a full year government spending bill in 2022. We talked about the figures we want for 2023. We want to thank members of Congress for their long-standing support of federal research. In terms of talking about NIDCR, many of you in your meetings probably have more direct experience than I do, certainly, in the important role that NIDCR plays in funding the research and science that you're doing. It is the largest oral health research funding organization in the world, and provides the evidence base for about 200,000 US dental practitioners. Investing in NIDCR gives the Institute the tools it needs to improve the oral health of the nation. It reduces the costs of dental care long-term. It's a smart investment, and it ensures a talented and diverse workforce. This increase in funding for NIDCR is important for addressing many of the emergent health challenges of the COVID-19 pandemic. This is something I'm sure you've read about in terms of how NIDCR, and Dr. D'Souza talked about earlier, addressed the pandemic through its research, addressed oral health disparities and equities, and has addressed some of the syndromes and diseases over the years that have been prevalent in our society, some of which are mentioned in the third bullet point under background on the talking points fact sheet. The last thing that we highlighted on that background section is sharing your personal story. It's highlighted because that is, and Megan will talk more about this in her segment, but there's nothing more important. If you don't remember any of these talking points, there's nothing more important than telling your personal story and your relationship to the NIDCR and to the NIH, and your journey in medical research and dental research, and how the NIDCR has helped you or your profession succeed and grow and address the oral health needs of ordinary Americans. Talking about it in a personal way is by far going to be the most effective way of influencing congressional staff and members of Congress. So think about that as you go into your meetings. How can you talk about this in a personal way? How can you make it relevant to your own life? Continuing on the talking point sheet, COVID-19, you can read through these on your own, but these are just some talking points on COVID-19 and the important role that medical and research and dental and oral health research have made in terms of addressing the COVID-19 pandemic and helping mitigate the impact of the disease on our population. So let's see, I think we're on the next slide now. Okay, so let's just move over to CDC, Division of Oral Health. The Division of Oral Health, we were pleased to have Casey and Anand talk about the important role that agency plays in improving the nation's oral health and reducing inequities in oral health. But the division promotes proven interventions. It has been involved in community water fluoridation and dental sealant programs. That helps reduce the rate of cavities, especially for at-risk populations. The DOH, Division of Oral Health, supports 20 state and territorial oral health programs. It collects surveillance data on oral diseases and develops and promotes adherence to infection prevention and control guidelines for dental health care personnel. The DOH supports integration of medical and dental care to address other chronic diseases associated with poor oral health. And the division has a strong residency training program, which helps strengthen the dental public health workforce. So these are just some of the efforts of the CDC Division of Oral Health. There's also a couple of talking points on the talking points fact sheet about the Division of Oral Health to help arm you in your meetings with congressional offices. We're also going to be talking, we should also mention, if you have the time, some of the other agencies. We're limited in our meeting time and in how much you can talk about. But if you have the opportunity to talk about HRSA's Title VII oral health programs, the National Center for Health Statistics, NCHS, the Agency for Healthcare Research and Quality, the AHRQ. These are agencies that you want to mention, and you can just say, we support robust funding, the highest possible funding for those agencies, which are also incredibly important for driving oral health research and science and oral health programs for Americans. In short, we believe that allocating resources to the entire research enterprise is critical for advancing the state of science, not just for dental and oral health, but for health in general, for Americans' health. Keeping in mind, discovering one area of research can be applied to another. So the collaboration between all these agencies is critical for bringing cures to all Americans. And that's why we want to see all of these agencies funded at the highest possible level in 2023. So let's go to the next slide. Authorizing and funding the ARPA-H, the Advanced Research Projects Agency for Health. In short, we are asking Congress to support the creation of ARPA-H and include a robust authorization that does not supplant funding for NIH. There's risk that ARPA-H could be funded and they'll just take that bucket of funding out of the NIH's existing funds. That's not going to get us anywhere. We need the NIH and NIDCR to continue doing what they're doing. And we need this additional agency, the ARPA-H, to play that kind of independent and a supportive and innovative role that is different and supportive of what NIH is doing, but in a different way. There's broad support, as I've mentioned many times, for biomedical research to help speed the translation of discoveries to treatments. And while there's some disagreement in Congress and policymakers about whether the new agency is completely necessary, you may hear about bureaucracy. There's also disagreement about how ARPA-H should be structured. That's something that very well may come up in your meetings. Should it be structured under the NIH itself, or should it be under the larger HHS umbrella, Health and Human Services umbrella? How should it be implemented? The types of projects that would be best suited in this model initiative. Key point there, if these questions come up in your meetings. We don't want to get into the logistics of how the agency should be established. We just want the agency created, authorized, and funded. So leave that detail about how it is structured, how it is authorized, up to the legislators. If these sort of questions come up in your meetings, say, we're supporting the authorization, creation of this agency, robust funding for the agency. We're not telling legislators where it should be situated. We just want to create it. And that is really, your job. It's their job to figure out the details. And in terms of the specifics, how do we want it created? Again, we don't really care, but we are going to be talking about the ARPA-H Act, HR 5585. Keep in mind that for ARPA-H to be created, it has to be authorized as a new agency by Congress before any funding can be appropriated to it. So it was proposed in the president's budget and in the Senate and House appropriations bills in FY22. And we may see it again in 23. So recognize that there is a funding mechanism and authorization mechanism under the appropriations process. But we will be talking about the ARPA-H Act. Now that second document in your training materials is the co-sponsor list for ARPA-H. The ARPA-H Act, HR 5585. If you can access that now, that would be good to look at. That document lists all of the sponsors of the ARPA-H Act. So we want you to kind of cross-reference that document of sponsors with the members that you're meeting with tomorrow. If they are on that sponsor list and they're alphabetical order, what we want to do in our meeting is thank them for sponsoring. Most members you're meeting with will not be sponsors. So our ask is please co-sponsor HR 5585. That means that they are a leader, champion of this legislation, and we can count on their support generally, if and when that bill comes to the floor for a vote. So take a look at that document, see if the member you're meeting with is a co-sponsor, thank them, and if they're not, ask them to co-sponsor the legislation. So with that, I think we are now going to do a Q&A. I think we're on time and in terms of the schedule. So if you have questions for me or Megan or Sharuk, you can ask them in the Q&A box, and we will answer them. So let me just check if anything's come in.
Yehuda, there are actually a few questions, and I think you were originally planning to field the questions, but I'm going to let you have a break with your voice and let me ask the questions, and you can respond to them as you're able, or if they're directed towards Megan. And there's actually a few questions from Dr. Larry Gettleman, and probably more than we can get to right now. So I think I have the technology to actually unmute Dr. Gettleman, and he can ask his most important question in that list. And unfortunately, I don't see we just had it a second ago. I'm not seeing the participant list where I can do that. Let me see this.
I just added him, so he should be able to unmute himself, Dr. Gettleman, and
thanks,
ask
Chris.
your question.
Go ahead, Dr. Gettleman. Well, he may have stepped away if he's. Oh, there it
No,
goes.
I'm here. I'm here.
Go ahead.
Okay. Well, I have several questions.
Ask your most important one.
Yeah, my former Senator Rand Paul of Kentucky has written to me several times after writing to him to support NIDCR. The government should just step away from biomedical research and let private industry take the lead. Now, my question is, what are the best arguments to counter this attitude, and what proportion of biomedical breakthroughs come from private industry versus federal basic research at NIH and other government labs? I mean, if that were the case, we'd all be dying at age 49 as we were 100 years ago of yellow fever.
Yeah, I mean, I'll just quickly say one thing on that and then defer to my colleagues. But, you know, one of the reasons we're talking about ARPA-H is that it fills that gap, as I was mentioning, and commercial private research is very geared towards the type of research that will result in specific drugs or treatments or tests that address that, you know, for diseases that are current right now. You know, they're not theoretical and abstract and kind of larger picture like some of the federal research. And so, you know, I think what we're talking about is the need to have both of those. We support commercial private research, but without federal research and the funding of the federal government, which, you know, far exceeds what private industry can do, we will not have the ability to address those, you know, our current needs in oral health research and future needs as well.
Meg, do you want to add to that?
Yeah, for sure. I would add maybe to allay your concerns, Dr. Gettleman, or others that may be concerned by this question, that is not the typical priority of senators and members of Congress. There is really vast bipartisan support for investment in biomedical research across the board in Congress. So like Yehuda mentioned earlier in his presentation, I think a lot of your meetings, you know, most of your meetings tomorrow will be very friendly. This is a very popular endeavor. So Senator Paul is a bit on the outskirts in that respect. And a good argument to make is, you know, a lot of private investment really doesn't take place for basic science. You know, they don't invest in that initial stage that is necessary to kind of have the building blocks. And the National Institutes of Health, of course, as you know, is the biggest institute focused on that. So I think critically important, as you all know.
Chris,
go ahead. Yeah, please.
Just stab at that. So, Dr. Gettleman, I have received that type of question before from my senators and representatives. And what I've focused on is explaining to them that a lot of the academic institutions and the smaller businesses typically do not receive funding from private industry. And the focus of research in academia and smaller businesses through the SBIR and STTR program typically is advancing science at the basic level, like Meg mentioned, also very mechanistic, fundamental type of research, and also now a little bit more related to innovative type of research. So I would, there's no numbers out there that we found in the past, but really the focus should be that it's a very different type of environment and a different group that's being funded, in my opinion.
Great. Thank you, Shuk. And I think a current example, obviously, would be the success with the COVID-19 vaccines. I mean, Pfizer and Moderna would not have been able to develop those vaccines without the investments of the NIH over the last 20 years. It seems like it happened overnight, but it did not. The next question I'd like to go to Jane Weintraub, who has a point that she'd like to make. And let me see if I can allow Dr. Weintraub, our president-elect of the ADOCR. I think you can talk now. Dr. Weintraub?
Good afternoon. Thanks for letting me ask my question. As a faculty member at the University of North Carolina, Chapel Hill, I am a state employee. And so we are not allowed in our state to lobby our legislatures and advise them on a specific ask. We are able to advocate and educate our legislators. So could you talk to that in terms of what we can or can't say tomorrow?
Sure. So that's a great point. There are, you know, some individuals who may not be able to quote unquote lobby. I think we'll talk a little bit about how to plan your meeting when we discuss that in the next session, but this is the point that maybe wouldn't have been brought up. You will have time in advance of your meetings. We're asking that you log on to the Zoom a few minutes early to kind of plan out your roles. And in doing that, if you have restrictions, make sure that that's taken into account when you plan these roles. So you are able to talk about your own research, the importance to the community of that research, and perhaps someone else in the meeting can, drill into the actual ask. But an important part of advocacy, which we'll keep talking about, is the stories and the impact to the community. And that is, that's educational. So you would be welcome to be able to share that. Yehuda, I don't know if you have anything to add.
And if I may just quickly add to that, there's a difference between the term lobbying in terms of the federally registered lobbyists. So those of us who apply for NIH grants, we're familiar with that term when we serve on study sections, et cetera. And so I tend to just stick with the word advocate during my discussion with them, and I don't bring the word lobbying up. But Dr. Weintraub, I think that's a very valid point that you bring up. So thank you for mentioning that.
Good addition.
Thank you, Shuk. Question from Dr. Riggs.
I just had a question. As you were concluding your presentation, which was excellent, you had said look to see if your member of Congress or senator is on the co-host list for the ARPA-H agency. Will you tell us if you know who we are meeting with? Will you tell us if any of my members of Congress or senators are one of the co-hosts?
Yeah, I think if you're able to access that co-sponsor list, which is on in the training materials, that has the full list of co-sponsors to that legislation. I think Syriac actually just shared the link to it. So you should be able to pull that up. So, if you're meeting with a member of the House and you see their name on there, thank them. If you don't see their name on there, they haven't co-sponsored, and ask them to co-sponsor it. And just a clarification, that's a House bill. So if you're meeting with a Senate office, it's not a bill that they can actually co-sponsor. So HR means House. So it's a House bill. It's not currently in the Senate. So this is just an ask and a thank you for representatives, House representatives, not senators.
And you should have received invitations through your calendar for all your meetings, which will indicate who you're meeting with. If you have questions about that, we'll go over that in the next session, but happy to answer questions about that as well. But that would tell you who your legislator you're meeting with is, so you can find them on the corresponding list or not, and then ask them to respond.
Super. Question from Dr. Ianadu.
Hi, everybody. Thank you for doing this. It's always a pleasure to have a review of the advocacy session, but I have been doing this for a few years now. And again, Connecticut is a democratic state, and whenever I go to those meetings, everybody's very welcoming and warm, of course, but they're like, yeah, we know, we support you, blah, blah, blah. So I feel is there any twist that I need, anything more impactful, or anything else that I can use besides that? It seems to me that I find that my advocacy half hour might be, kind of useless for Connecticut. So I wonder if I'm making an impact, or it's just, a reminder call for them. I just to clarify on this.
Chris, may I tackle that one?
Go ahead.
So Effie, what I've noticed is that when I tell them a little bit about my funding, what is the area and what's the significance, if you will, of that funding, I've noticed that the staff and the representatives and senators pay a lot more attention. So what Megan and Yehuda talked about a little earlier, personalize what you're pitching to them. And I've noticed that even unintended consequences are that later I'll get a phone call from them a month or two later when they have a question about a specific aspect that's being discussed or something legislative that's being considered. So if nothing else, they remember that, oh yeah, I talked to Dr. Ionadu and she's a periodontist and this may be a question I can ask them. So it works in multiple ways, but pitching that personal research that you do, I think really drives that message home.
And I think that's absolutely right. And I would add one more thing, which is that, and I'll go over this again too in the next session, but when members of Congress put together this appropriations bill, there's thousands of lines of spending that they have to consider. And you don't want your line of spending to be the one that they weren't reminded of. They didn't have a constituent meeting, so that one sort of fell off the priority list for them. So even if they're genuinely supportive, when you meet with them, it was still critical to have that touch point that reminds them that this is an important program to fund when the list of programs needing funding is so very long.
Yeah, this makes sense. Thank you so much. I appreciate it. And Meg, I know that you mentioned that we will revisit the appointments in the next session. So I will have a question on this appointment thing for to come, like in a few minutes. Yeah, thank you.
Great. And seeing no new questions, we are precisely on time. So let's turn it over at the 11:20. We're doing meeting tips and tricks with Megan. Go ahead.
I think I need to share my screen again. So we'll see if I'm more successful this time in doing that. Does that look right to everyone?
We are again seeing your presenter view. So if you go to display settings and flip that.
Display settings.
Perfect. Great.
Okay. All right. Well, let's get into the tips and tricks. And some of this might sound familiar. I think we've had a little bit of crossover as we talk about all the different things, but there's no reason not to emphasize these key points. So Yehuda mentioned it, and I'm going to talk about it a little more, but sharing your story is the most important thing, in addition to making the asks that you can do in these meetings tomorrow. We're talking about the appropriations process. Congress is obligated to complete the appropriations process and fund the federal government, but how do they make their decisions on where to invest these federal dollars? Like I just said, there are literally thousands of programs and just as many stakeholders competing for important federal funding, and Congress has to make those decisions line by line. So you want to be there and making the case for biomedical research and for your work. First and foremost, members of Congress represent their constituents, like you. So your message is most important because it comes from back home. And there's an expression too in DC that if you're not at the table, you're on the menu, meaning get in there and advocate for your priorities, or it could be the thing that gets totally cut out. So whether you're an experienced advocate or a newcomer, you're the subject matter expert and you're the community expert. So tell your representative and their staff about why investment in dental research is so critical. And like Shrik said, talk about the work you're doing back in the state or district. And the more you can make that connection between what these funds and programs do at your institution or back home, the more likely the member of Congress and staff are to prioritize it. A lot of policy decisions are actually local, even though members of Congress are sort of isolated here in DC. They want to hear from their constituents. So meeting prep, and Yehuda talked about this a little bit too, but to go a little deeper, whether you've met with your representatives and senators before, or this is your first time, it's always helpful to do a little bit of preliminary research about their priorities before your meeting. So you'll know who you're meeting with based on your calendar invitations. And if you have a moment, we really encourage you to visit their official websites, learn where they stand on issues that affect dental research and oral health, particularly biomedical research. You can also scan their press releases or do a quick Google search and see if there's any recent news articles that indicate their support for biomedical research or any of the other asks. If there's scant information on these topics, that might be instructive because maybe that's an opportunity to do some education like we discussed and recruit a new champion for dental research on Capitol Hill. Another good idea is to learn what committees and subcommittees your legislators serve on and determine what impact that might have on the Advocacy Days asks. For instance, if you're members on the Appropriations Committee, he or she will have direct influence on the federal government's investment and the process we've gone over. Make sure, of course, also, like Yehuda said, to familiarize yourself with the legislative asks from AAD-OCR and review the talking points and the leave behinds. The leave behind materials, they're called that because in an in-person meeting, you'd bring them with you and leave them behind for the congressional staff to review and reference. We have shared those via the calendar appointments, so you don't have to worry about linking to them. They'll be available to the staff going forward. And again, be ready to explain how dental research, including your own research, benefits the state and district. I don't think that can be overemphasized. They want to know what's going on back in their hometown and how they can impact it and why it's a priority. So here are some tips for a successful meeting, and we'll go over logistics a bit too, but these are more kind of overarching tips. When you get to the Zoom, don't quickly dive right in. Make sure you greet the staff or the member of Congress, provide an opportunity for all the participants to make introductions, share what institution they're with. Like we discussed, talk about AAD-OCR and why you're involved, and the Friends of NIDCR. You'll also want to, again, frame your request with your personal story and the benefits of dental, oral, and craniofacial research to the community the legislator represents. You don't have to stick to a script, but I would recommend having those talking points handy. They're a helpful guide, and you can share the highlights and make sure you familiarize yourself with them. And above all, make sure you relay the ask before you run out of time, and share why those asks need to be either funded or why the member should co-sponsor the bill. Ideally, every participant will have a role in the meeting, and we'll talk a bit more about planning on the next slide. But just for awareness, there are some states with a lot of participants here. So if you get into particularly a Senate meeting, for instance, the states of Massachusetts, New York, and North Carolina, those will be larger meetings. So it might be more difficult for everyone to have a strong role, but please, again, get on that Zoom a little early so you can work that out and make sure everyone has the opportunity to introduce themselves and speak a little to that. You may also be joined in your group by individuals from other states. We want to make sure, especially the newcomer advocates, aren't traveling, though virtual, traveling alone. So you may find someone who's not from your state, and maybe they're not represented by the member or senator you're meeting with. So in that case, again, you want to get there early and plan it out and consider giving stronger roles like the making of the ask to the folks in the meeting who are constituents of that office. And you may also be joined by AAD-OCR staff to provide some support as well, if you have a smaller group. Meetings are generally scheduled for about 30 minutes, but Capitol Hill is a pretty busy place, even in this often virtual environment. I like to give the tip that, the staff might have limited time, something might have come up on their schedule. Make sure you're respectful of the clock and keep everything brief and concise. The best meetings are two-way conversations, so do encourage questions and comments from the staff. That'll help you learn more about the member's position, even if they don't state it directly, as they sometimes won't do. If you get a question and you don't know the answer to it, just say that you're not sure. Write that question down. You can follow up with AAD-OCR. We will help you provide that answer, but it's better to do it in follow-up than to get the answer, have an incorrect answer. So, and always, even if you get a question you don't know, that's perfectly fine. I would not worry about that at all. It even provides a good opportunity for follow-up and help you build that relationship moving forward with that office. And even if without any questions to answer, follow-up is critical to relationship building. So you can ask the staffer to share their email address and reach out via email to thank them for the meeting and make the asks again. So a little bit more of the nitty-gritty logistics. We're still operating virtually, but these are official meetings with members of Congress and their staff. So we'll treat them that way. Please dress professionally. Again, to make logistics plans with your group, including setting roles for the larger groups, please plan to log into your Zoom meeting at least 10 minutes early. You may not need to do that if you're with the same group throughout. You may have gotten into the swing of things, but essential to log into your first few meetings early at least. Again, when you open the meeting, because there may be scheduling conflicts that have come up, it's helpful to sort of say, we have this scheduled for 30 minutes. Do you have any conflicts? Is that amount of time okay? Or, we want to respect your time. Again, exchange your contact information. Make sure you follow up. You should have received your schedule through a number of calendar appointments electronically. The Zoom link will be there. So for each appointment, you'll want to go separately into that appointment and log on to that individual Zoom link. Just keep an eye on your calendar and your email. These meetings are pretty set right now, but things can come up and rescheduling can be necessary. So if there are any changes to your schedule, you will hear directly from James Kennedy, my colleague. And if you have problems with your schedule, you can reach out to him as well. For instance, if the Hill staffer doesn't show up to the meeting, I think you'll see James's email address on an upcoming slide. And just one more flag for a couple of groups. If you are from California and you have a meeting with Speaker Pelosi's office, they've asked that that meeting be held via Microsoft Teams. If you're from Alabama and have a meeting with Senator Tuberville, that meeting will be held on WebEx. So those are different platforms than Zoom. If you've not used them before, you may need to take a moment in advance of the meeting to make sure your device is equipped to use those platforms. Oops. So here is just some overarching do's and don'ts. A lot of them are self-explanatory, but we'll just walk through them quickly anyway. Express your gratitude. Just say thank you. We're glad these members have taken the time out to meet with you this week. As I said earlier, it's a very busy week for the appropriations process. So it's nice to be able to have the opportunity to meet with staff now during this important time. Don't forget your personal story. Keep your message simple and as brief as possible. There are a lot of asks, so we want to make sure everything is succinct. Stick to the agenda and make the ask. Some of the don'ts, watch the clock. Make sure you stay within the parameters of the meeting. Don't be, political, as Yehuda said, or confrontational. There's not a place for that in these official meetings. Keep things simple for the lay person. And make it about, your institution and the impact of research. Of course, I know you all will, but important to make that note. So those are some of the overarching tips that we have. And I think with that, we are ready to take your questions.
I just wanted to, thanks, Megan. Quickly, I think on 2 slides ago, we listed the leave behind materials. I don't know if you're able to pull that up. Yeah. There it is. So just so you know what those are and can reference them in your meetings. The organizational asks is a 1-pager that just very briefly mentions our 4 asks. So that's what the staffer should be looking at and should have during the meeting. The multi-society letter is a letter that we signed on to, AADOCR signed on to for fiscal year 2022 funding priorities. So it's, again, we're kind of focused on 23, but just so that they can kind of have our messaging in terms of the need and request for robust funding for NIH and NIDCR and research in general. The oral health report fact sheet is from the NIDCR. It's a 1-pager on their Oral Health in America report, which was released just a couple of months ago. And that's an important fact sheet that demonstrates the important work of the NIDCR is doing. And then the co-sponsor request is a letter that we have we've tailored to make kind of general, just as dear representative, so it can go to any House member so that they know our specific requests regarding co-sponsoring HR 5585. So I just wanted to mention that. And that link has also been sent to all congressional staff so they can access all of these materials. Again, thank you everyone for bearing with me with my voice today.
Okay, we have a question from Rebecca Strong, and I think this is a question for you, Meg. Will the AADOCR be sending one-pagers ahead of our meetings, or is it up to our advocacy team to send one? I think you mentioned that they're in the calendar invite. Is that correct?
That's correct. The link to all the leave behinds will be in the calendar invite, and the Hill staff that you're meeting with will have received the calendar invite as well. So they have that available to them, and you can reference it in your meeting. You can tell them, look out for these materials in your calendar request. And if you're following up, you're very welcome to share that link again through email. That's emphasis is always helpful, but you don't have to worry about it for your meetings tomorrow.
Very good. Although there are some people of a certain age, like myself, that don't realize that there's a link, that there's an attachment to the Outlook invite. So you can certainly remind them of that it's there.
Absolutely mention it, but you won't have to
Right.
proactively share it.
Great, thank you. Any other questions specific to the meeting or meeting questions? I think one just popped in from Effie. I think that's a specific question with her meeting schedule. So
Yes,
the rep is from Georgia. Do you have a response to that, Yehuda?
No, any specific questions regarding your meeting schedule, we're going to do in about in just a few minutes after we have closing remarks. And just anybody who has, again, specific conflicts, questions, or concerns about their meetings tomorrow, just stay on the webinar and we can address them individually. But let's just keep this open for another minute or two to see if anyone else has any questions about our messaging, about meetings in general, about our materials that we're giving to members. If you're unsure about appropriations, anything that you want to ask for the benefit of the group, please put it into the Q&A section below.
Meg, you had a slide on do's and don'ts, and unless I missed it, I didn't see in the do list a follow-up correspondence. Is that still recommended?
It
follow-up
is.
after the fact? Okay.
Yeah, I'll say if that was missing, then it wasn't a comprehensive list of do's. There are other things you can do.
Maybe I missed it. I don't know.
No, I don't know. I don't remember, but you should, thanks, Chris, for reading that. You should definitely follow up. If you don't have the staffer's email handy through the appointment request, you can ask them for their email and for sure follow up, especially to say thank you, but also to reiterate the asks and answer any questions that came up in the meeting.
Great, thank you.
And I'd remind everyone again to I know we said it before, but just to log on at least 10 minutes before your meetings with staffers so that you can decide who's going to say what in the meeting, who's going to do the intro, who's going to talk about the organization, AADCR, who's going to do the official ask, who's going to talk, provide an anecdote, all within the confines of the 30 minutes or so you have.
If I could just add one more additional piece of advice, something that I've been asked often before is, did the NIH funding or NIDCR funding create new jobs in the state? Or did it provide new training opportunities, et cetera? So if you've had those, you were able to bring in students or postdocs or junior faculty to participate in your grant, then think about that perspective and tie it into that personal expression when you're describing what you've done. I think that really helps them understand how the state benefits.
Good point. Okay, I'm not seeing any other specific questions to the meetings, but again, I'm just going to do a quick wrap up, like 2 sentences, and then if you do have a specific question on your meetings, you can stay on and ask those questions to Yehuda and Meg or Sharuk. And as a wrap up, let me just thank once again our 2 main guests from the federal government, Dr. D'Souza and Mr. Hannon. They both gave fantastic presentations, and we will make those available to you. And it's not for you to memorize that and repeat that tomorrow during your meetings, but it's just really to communicate the excitement of the science that's happening at NIDCR and all the wonderful CDC oral health programs that's sort of top of mind. So we do thank them for their participation. I want to thank Yehuda Sugarman for pulling all this together under somewhat duress, at least under the last couple of days with his voice, and I'm hopeful that will get better. And Meg Riley, and I know Erin helped you in pulling these materials together. Sorry she wasn't able to join us, but thank you for that. Very helpful information on the actual meetings. And Shruk, for your leadership as a government affairs. So thank you very much all. And most of all, thank you to the participants and those that will be joining the visits tomorrow. And that's why we're all here. And thank you so much for tuning in to this training session, and good luck with your meetings tomorrow. And we look forward to hearing how they went. So I'll turn it back over to Yehuda and Meg if anybody has any specific questions, but I will log off. Thank you.
Thank you, everyone. Thank you very much for attending and for